Hello and welcome back to the Western Victorian PHN's Project Echo Hub. This series is about intellectual disability information and education and is part of the SPIDAH Echo network. So today is Tuesday, the 19th of July, 2022, and this is our first session of the second series. We've called this session, What on Earth are Reasonable Adjustments, Part 2. So I'd like to begin by acknowledging the traditional owners and custodians of the lands and waterways from which we're all zooming in from today. We recognise their diversity, resilience, and ongoing place that the First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit of mutual understanding, respect, and reconciliation. We support self-determination of First Nations peoples and organisations, and we work together on closing the gap. So my name is Dr. Robert Ward, and I'm the GP facilitator of this Echo series on intellectual disability. These echo sessions are designed to generate some conversation ideas we can employ in our practices to achieve better health results in this population, assisting people with intellectual disability to access health better. They're held fortnightly, and this is our 5th session to date. So far we have discussed diagnostic pathways of intellectual disability, communication, and our last session was on consent. Today, we're going to explore the important concept of reasonable adjustments for the second time. Today, I'm very excited to be joined by Elica Petroska, as co-facilitator. Elica and I recently gave a version of this session to the WestVic PHN staff. Elica has lived experience with intellectual disability, and her insights are valuable in understanding the barriers people face with intellectual disability and the way we can assist reducing these. So it's a really important subject today. So we'll just have a look at the etiquette slide just very briefly. I think we've all seen it before. We've got a big session today. So just to remember that the session is being recorded, so you can follow it later on. I suppose the important thing about this session today is to turn on the closed captions, which is the button down the bottom of your screen. I think if you allow closed captions or allow subtitles, that will help with our communication today. So if you can have a go at that, and also remember the new time sessions for these sessions are 7:30. So I'd like just to firstly welcome the WestVic team members. I think Whitney and Jana are around. We've got Kerry from the SPIDAH project. And our session today is going to be co-facilitated by Elica Petroska. So Elica is one of the leaders of the Geelong Peer Action Group with Valid, which is an advocacy organisation. And as a group, they set individual goals and work on group projects to promote inclusion for people living with disabilities in our local community. Supporting Elica is Jana Hand, and also to help us today is Sharon, Elves, the practice facilitator from WestVic PHN. Now, normally with the echoes, we would go around and maybe introduce everyone, but I think really with the time frame today, we've got a lot to get through with Elica, so we're going to just go through our presentation today, and hopefully we'll have some time for discussion at the end of it. So just a reminder about patient case studies. Case studies are an important part of the echo process, and they also help sort of us with our discussions about important subjects. So if you do have any cases, please feel free to submit them to the Echo team, and they can work them into these presentations. A reminder about professional development, that we can get points from these sessions, and so that would be important if you want some professional development points. We've got, there is a survey to do, a pre-session survey, if you can. So if you wanted to click on that, and the learning outcomes. So I think throughout the series, we've had the learning outcomes really to increase our understanding of intellectual disability and the barriers people face, and understand the rights of people with a disability and our legal obligations as health partners. And the important one down the bottom, which is probably relevant today, is implementing reasonable adjustments in the primary healthcare setting. So learning outcomes for this session, to identify the clinical resources, to guide best practice when providing primary health care for people with an intellectual disability, to discuss appropriate accessible consumer resources, and to describe adjustments to standard practice that may help overcome the barriers for people with an intellectual disability. So really, I'd like to welcome you all today, and we're going to start our session today. So what on earth are reasonable adjustments, part 2? I'd like to just state that these slides were brought together by the Council for Intellectual Disability, which includes involvement of people with lived experience with intellectual disability. And the slides have been adapted by the West Victorian PHN SPIDAH project team as part of the training that we're doing today. So I'd like to acknowledge people with lived experience with disability, as well as their families, carers, and disability services and advocates. We recognise their strength and courage and unique perspective is a vital contribution to our work to learn, to grow, and to achieve better outcomes together. We recognise that people with disabilities have the right to enjoyment of the highest attainable standards of health without discrimination on the basis of disability, and the same rights as every other Australian to have safe, effective, high-quality health care services that meet their needs. So I'm Robert Ward, and I think I've probably met most of the people in this session before. I'm a full-time GP working in a group practice in Geelong. I've got a child with an intellectual disability who's now 25 and lives at home and accesses a lot of services, including the NDIS, day programs. And throughout my life journey, I've come in contact with many organisations and people and paediatricians and families who have intellectual disability or family members with intellectual disability. And really, my son's 25 now, and I reflect on my journey, and I realise that at this moment there's going to be a baby that's going to be born, or to a new family's being formed, where that family is going to go through a similar but different journey to my family. And it's all going to be very new for these new parents, these new grandparents, these new siblings, to have a family member with an intellectual disability, and maybe not something that they've planned. But as health professionals, we're on the front line of providing primary healthcare services to our community. So it's important that we equip ourselves to best support and guide and advocate for people with intellectual disability and their families. The health system can be complex, mystifying, and infuriating, and inflexible at the best of times. So we have the opportunity as health professionals to make the system more accessible, more relevant, and more caring. And to do that, we have to open our eyes and educate ourselves and put ourselves out there to advocate and champion and speak for positive change. So that's why I'm here today, and I'm delighted to be joined by Elica to present this Echo series for you today. Hi, Elica.
Good morning, thank you. Good morning, Dr. Wood and everyone who's here present. My name is Elica. Thank you for giving me the opportunity to work with you side by side to improve your health department. I am one of the leaders for the Sharon Peer Action Group with Barrett and Adversity Organization. My group plans individual goals and projects to promote awareness for people living with different kinds of disability in our local community. We speak up for ourselves, make sure everyone is treated equal with dignity and respect. The group have said they don't like going to the doctors. I am very happy to help to make all people feel safe and welcome when they go to the doctor. housekeeping. I have an intellectual disability so that we can understand. Please do not use difficult words and speak a little slowly if you are sharing or asking a question.
So the format of today is Elica will present most of the slides, including information about the current healthcare system and how it is working or not working for people with intellectual disability. Elica will then introduce the concept of reasonable adjustments. This is, as I've spoken in the past, it's not a term I'd really heard of before being involved in this project. So I'm really keen to hear Erica's take or Alicia's take on this concept and how it affects her and how we can make these adjustments to our practices. Throughout Alicia's presentation, I'm going to share some additional thoughts from the clinical and GP lens. And then at the end of the session, hopefully we can have some questions and have a discussion about reasonable adjustments and where that fits within our practices. Yeah, thanks, Elica.
I tried hard to submit one of the best in the world, and many feel to have good health. But it comes much worse for people like me living with intellectual disability. What to do? Percent of people in Australia have an intellectual disability. We have worse physical and mental health. We have doubled the number of deaths that could be avoided. An Australian study feels that we are 27 years younger. Many of us have complex health conditions that are difficult to diagnose, and sometimes the signs of illness are not so clear. Communication can be harder in both directions, but we want to be healthy. We have right to go. We have right to good health.
Look, I'd have to agree with Elica that Australia does have a great healthcare system. We're generally well funded and inclusive, and we have workers who are well trained, professional, compassionate, and caring. And also, as a health profession, we also have the ability to look at ourselves and identify the things that are not going well and to work together on solutions. So I suppose that's really why we're here today, isn't it? Last year in July, the federal government released the National Roadmap for Improving the Health of People with Intellectual Disability. And in exploring some of those issues, the roadmap tells us there's 450,000 Australians with intellectual disability. And as Elica said, these people have twice the rate of avoidable death, twice the hospital and emergency department attendances, and substantially higher rates of physical and mental health issues. And there's have significantly lower rates of preventative health, which I suppose in primary healthcare, that's one of our core services. So screening, bowel, breast and cervical screening, immunisations, dental care. And I suppose even basic stuff, if you look at blood pressure, skin checks, cholesterol, or even just access to the doctor, seeing the doctor on a regular basis can often be really difficult for this group of people. So the roadmap excuse me, the roadmap produced by the federal government had a strong focus on communication, and really communication is one of the most important aspects of our job, because communication helps us understand the patient and what they're really trying to tell us. It helps us gain good information from them to make diagnoses and to offer health advice. And also, as Elica said, it goes the other way. Health information is also important about how we give that information to people. People can't take responsibility for their health if they don't get the information in a way that they can understand and the way they can use. So, I mean, giving appropriate information in an appropriate format becomes a real important aspect of primary healthcare. Communication is also important, getting appropriate consent, as we discussed a few weeks ago. Understanding the patient, allowing the patient to understand the health system. So for people with intellectual disability, communication, excuse me, can be difficult, and it also could be different. So many may need pictures or diagrams, may need written instructions to take home so they can look at them again and again. Some may need a simpler language with no medical jargon. I think we often lose track as medical professionals how much medical jargon we use. So even people without an intellectual disability can often struggle. So people with an intellectual disability really don't need the medical jargon. We have to make sure that they understand. So some people have never been even given medical information or health information in a way that they could understand in the past. So their base of communication and base of understanding is lower, and we have to help bridge that gap. Some patients have no language at all, and they communicate through behaviour, so often called complex behaviour, changing behaviour, behaviours of concern. So a person with an intellectual disability may have a headache, nausea, a mouth ulcer, chest pain. They may be cold, sad, anxious, or just bored, and it could manifest itself as a change in behaviour. And it's our job as health professionals to help or to make the adjustments so we can communicate that and understand that. People with intellectual disability often have a complex healthcare needs. So communication is really, really vital. So taking the time and really listening so we're not missing anything. Elica also spoke about the right to access healthcare, and it is a basic right for everyone to access the best healthcare without discrimination. It's our responsibility as health professionals to facilitate that. So currently the health system is very complex, and it's often inflexible. It's often designed for efficiency and throughput, one size fits all, and God help anyone who doesn't fit that model. And often people with an intellectual disability or complex health needs don't fit into that system, and so find themselves up against a lot of barriers all the time. I think Elica in her introduction stated that many of her peers didn't like going to the doctor. And that in itself is just a barrier, just not liking going to the doctor for whatever reason. And Elica also stated that people wanted to feel safe and welcome in a health environment. And I'm sure that's all what we want here, is for people to feel that way when they access our health services. The other thing is, many people in the health industry may not be confident with the care of people with an intellectual disability. They certainly may not have had any formal training. I know medical students, and certainly my generation, didn't get much formal training at all about people with an intellectual disability or communication. So I suppose thinking about how we can do that better and how we can give information to primary healthcare to work in a way so they get their confidence and can feel more confident in providing healthcare in a primary setting to people with an intellectual disability. So the roadmap also stressed the importance of engaging directly with people with an intellectual disability and their families and support workers, and to listening to their thoughts about how we could do things better. So that's why I think it's great to be here today, and it's great to have Elica here today to learn how we can all do things better. So thanks, Elica.
Okay, the next one is, I think small changes can have a big impact on personal health care and help to remove barriers to getting good health care. And examples are when the client wants and waits at the waiting room, one enough space can fit the wheelchair and turn around easily. Also, everything needs to be within reach to help with filling out forms on the day. That one is in the doctor room. One in the space needs fit the wheelchair and can turn around easily. Two, the client needs to be in the room, not the support worker and not parents.
Thanks, Elica. So really introducing this concept of reasonable adjustments. And so when I first heard about it, I had to Google the term to work out what reasonable adjustments were. But as I've gone through this process, I realized just how important and how empowering they are for both doctors and staff to understand the concept of reasonable adjustments. I love, Elica, your statement at the start, which is reasonable adjustments are small adaptations that can have a big impact on the healthcare of an individual. And I think that's emphasizing those small adaptations can be amplified and have that huge impact is really important to know that everyone can play a role in making those big changes for people. So I just want to do maybe a little, we don't have any case studies today, but I just wanted to run through an example of maybe considering if we all consider ourselves going to the general practitioner, and maybe we do have an intellectual disability and mobility and communication issues. So you're going to go to your GP, but you're running half an hour late for your 3:30 appointment because the maxi taxi you've booked was late. The support worker who comes with you doesn't know you very well because the 3:30 appointment time is not when you can access your regular support worker. In fact, you had to leave your day program today early to get to this doctor's appointment, and no one really told you why you were going. So you're a little bit cranky leaving your day program because no one has explained anything about why you're going with someone you don't really know to a doctor's appointment that you don't know why. So you get there half an hour late. The receptionist is really a little bit cranky and annoyed with you, and well, she doesn't say outright. She probably gives you a bit of a look and ticks off your care worker. She talks to your care worker because she's running late, you're running late, and you just should be grateful that you're getting seen anyway by turning up late. She'll sit you down by the noisy kids in the waiting room because that's the only place in the waiting room where the wheelchair will fit because there is no other designated place. So the doctor's running a bit late, so you're sitting there with these noisy kids. You're getting a bit stressed because you've left your day program and you're with someone who doesn't really understand you, and they're probably just on their phone. So eventually you come into the doctor. You don't know why you're there. The care worker doesn't really know why you're there, but he brings a medication chart because that's what he's been told that you need. And it just needs a signature from the doctor. So as a doctor, your doctor looks at your chart. It's got some psychotropic medication on it because that's what you've been on for a long time, and you're getting really sort of agitated now. So it's pretty obvious to the doctor that you probably still need those psychotropics, so he'll sign off on them for the next 6 months. So the doctor will assume that this is just signing off on a medication, and the care worker will assume that it's your medication review every 6 months, and that's because that's a really important document. So you're getting pretty noisy and cranky now, and everyone's a little bit stressed, so you can't possibly do your blood pressure because you're thrashing around too much, and the carer has no idea about how to communicate with you or what the problem is. And then, by the way, they also need an epilepsy plan signed off as well, so the doctor will just sign off on that. And by this time, you've lost it. So everyone decides it's time just to call it a day. And you're out of the room. being loaded up. The doctor thinks he's doing a good thing because he's going to bulk bill you because he can't charge you for that. And in the end, you've had this consultation that probably everyone feels a bit stressed about and overwhelmed. So if I look at that, probably the doctor thinks he's made a number of adjustments to his normal practice. He saw you when you were running late and he probably wouldn't do that normally. He's bulk billed you and he probably wouldn't do that normally. He didn't speak to you, he spoke to your carer. Normally a doctor would probably speak to the patient, and so he's made an adjustment there, which probably wasn't right. The receptionist did it as well. It didn't explain to you while he was checking your blood pressure, so you didn't really understand what he was doing then. He didn't seek any consent about you and talking to your carer about you. And he rushed some very important reviews, like a medication review and an epilepsy review, because you'd only had a standard appointment booked. So probably an overall terrible outcome for everyone. So I probably just want to use this just to maybe look at some adjustments that could have been made. And the first one is maybe to consider an appropriate time for a patient to see a doctor. 3:30 is a terrible time to try to get a maxi taxi or a taxi in any, because everyone's getting picked up from day programs and specialist schools. So maybe an early morning or late afternoon. And I suppose it's up to us as doctors and primary healthcare workers to work out how we can make those times available for people with an intellectual disability. So the availability of the carer is probably really important for a carer who knows the patient to come with them. They will know how to facilitate the patient having the best experience at the doctor, whether that's helping them communicate, or whether it's knowing how to interpret some of the behaviour or what's really needed. Looking at the appropriate appointment, I suppose if it's for something like a medication review, these are really important, and they're not something that can be just rushed in a 15-minute appointment. So I suppose planning and pre-planning when we're going to see someone and how long we're going to see someone. I mean, maybe that needs to come from the doctor. We need to see you, in 3 months' time for a long appointment with the plan to review the medications. It's important that our staff are also on board with communicating with the patient. It's not appropriate just to talk to the care worker. It's always appropriate just to communicate with the patient themselves. Elica alluded to sort of accessibility, so finding a nice quiet spot in the waiting room. With the adults. Not the kids' table at a wedding here. This is sitting with the adults in an appropriate spot in a waiting room, engaging with the patient, asking permission before we do things, even things like checking the blood pressure. For a person with an intellectual disability, they may not understand what you're doing, and so a really good communication and consent, and using words that the patient will understand. I often use words like, this is going to feel a little bit tight, a little bit like a bit of a hug around your arm, rather than words that might make the patient frightened. We need to remember, as part of our reasonable adjustments, preventative healthcare, and be a bit more proactive with arranging reviews of preventative healthcare, and being careful with important things like medication reviews, and to show some leadership that these are not something that's just signing off a drug chart. And maybe if we're ever faced with this scenario, we need to inform the patient and the carer that they need to return for a proper medication review, because it's not something that's just rushed. It's not just the signing of a drug chart. I think making a review appointment is really important, and communicating this in a way that the patient understands. So I think, health professionals have a responsibility to embrace these reasonable adjustments, and choosing to sort of proactively promote how we can do a better consultation next time. I think we always have to remember that a lot of other people are watching us and the way we interact with patients. I think our staff will watch us, the way we interact. The carer will watch us, the way we talk to the patient, and they will take that away. This is the way the doctor talks to the patient, so maybe that's the way I should. Carers will watch us. parents will watch us and family members. You know, if we never talk to the patient or directly to the patient or have that interaction without them, then the carers will think that that's a normal expectation. And they won't give the patient an opportunity to advocate for themselves or to talk for themselves. So I think we have to set the bar fairly high for ourselves because we're going to be leaders in this area and other people are going to follow us. So thanks, Elica.
Before I see the doctor, they might be done by the health worker or the people working here. One, book appointment when needed. 2, ask what I need, like who should be at the operation appointment with me. 3, happy with filling out forms on the phone. 4, sending a form a week before so I have enough time to fill it out. 5, call or text it one day before I need to come. 6, checking if I have computer to not send me email if I can't get it. 7, if I can't read very well, don't send me 5 pages later. Please give me a phone call. 8, booking a long appointment or event coming to my house. The last one is booking packets at the same time as appointments.
Oh, thanks, Elica. I think there's a really all important administrative and systems changes that we need to look at. And often these reasonable adjustments need some pre-planning and some teamwork from all our team. I'd like to really get rid of some of the systems that actively put up barriers. As Elica said, you know, replying to a long online survey before you have your appointment. I'm probably not thinking about general practice, but maybe sort of the tertiary institutions often require people to complete quite a long questionnaire before they're seen. And I think that can be a barrier for people with an intellectual disability. Answering the phone. Some people with an intellectual disability, you know, or maybe autism, won't like answering the phone, especially from an unknown number. So it doesn't matter how many times you phone them. You know, if you can't get through, you haven't actually passed on that message. And I think if you're not passing on the message, that's not effective communication, and we need to find some other way to do that. And one of my bugbears is always removing the patient from a waiting list just because they haven't jumped through the hoops that some administrative person has said they have to jump through before they're given an appointment, and then not telling them that they've removed them from the waiting room, they've removed them from the waiting list. I think as someone mentioned the other day to me, is like a lot of doctors have online bookings, but it only allows you to book a short consultation. It's only the 15 minutes. So maybe some way that someone can still use the online system, but book that longer appointment that they need because of their disability. I think there's also some pre-planning in the medical records as well. I often look through my medical records, and the preferred way of contact, or the contact person, is not often clear in the records, whether that's the patient themselves and how they like to be contacted, or whether it's a carer or a care provider. I mean, who can we talk to, and maybe updating those details. especially for the staff who don't know the patient that well, and we can certainly have embarrassing or difficult conversations where staff at the front won't interact with a carer because they don't have consent and the patient's over 18. And we're continually telling our staff to, we always need to talk to the patient and talk to the person's and get consent from the patient. But when the person has difficulty with communication and they need a carer, we have to have some way to identify on the health record for our staff. Up-to-date contact details. So if we do get an abnormal result, we do know how to contact someone. And always getting consent before we do engage with carers, I think is also important. Before you've seen doctors, I think I've also been thinking with reasonable adjustments, information in a format the patient can understand. If I think about the number of people who, with an intellectual disability, who I've given a flu shot to, and the whole thing about the flu shot, it's a little bit of a surprise. Suddenly the doctor's there, suddenly giving a flu shot, and the patient may not have been given that information, or certainly not given that information in a way they can understand. Maybe an easy read form to explain exactly what's going to go on in a way that the patient can understand before they have their immunisation is something we should be working on. And health checks as well. Even talking about sort of care planning and producing documents that in a way that the patient can understand, that are useful for the patient and they can take a little bit of ownership for in the future. Making sure the appropriate carer attends if required. Some people obviously don't need anyone to be there, and as Elica said, sometimes we need to make sure that a carer or the parents or that supportive person isn't in the room with the person with an intellectual disability, because they do need some privacy sometimes, and they do need to be heard, and we do need to practice listening to them to see what they want. And sometimes having a carer in the room can make that difficult. And sometimes we need to also teach carers and parents that it is okay to allow the patient to talk for themselves, because sometimes they do sort of take over and start talking about their own health needs, or so I suppose that's another thing that primary healthcare, we can model our behaviour to teach others. Pre-planning with the staff, so involving all the staff, and flexibility in asking the patient and checking with them what their needs are, and don't just assume that what we think they need is what they actually need. So I really understand, Elica, when you spoke about needing multiple appointments for a patient to feel comfortable. And I think that's okay. We need to accept that people may need to see us a number of times. I would imagine that a lot of parents out there with kids with intellectual disability have been to the hairdressers a number of times to comb their hair or to brush their hair before they actually get a haircut. And that's okay. It's a practice run, and we all need to feel comfortable with what we're doing. So I'd like the outcome is to allow people with intellectual disability to feel safe and welcome in the healthcare setting, and to access the information in a format that they can understand, take with them on their health journey. So thanks, Elica.
Yeah. When I come to see the doctor, you ask me what I need, like a quiet spot to write. You can let my family and other spot people write outside in the car or in another room. I need people to talk and listen to me rather than those supporting me. A lot of people with intellectual disability see a lot of different doctors, and record can help use communication. One, I need the doctor and other staff to look at my health records, to make notes on my personal phone, like plain English, give me the ways to be able to access information such as apps on my phone or iPad, which helps me remember and understand my illness and treatment.
So I suppose this is a really good reminder that we need to ask and listen to our patients to see what they need and how we can communicate best with them. So people with intellectual disability have a wide spectrum of ability, really. So we need to use all our skills as primary healthcare providers to listen to what the patient is trying to tell us. So either that's spoken language, signs, picture boards, or behaviour. And maybe someone who knows the patient well can help us do that. But we also have to remember that the person who's helping the patient can't speak for the patient or decide for the patient, and should really just be supporting the patient in their communication. We talked about before about sort of modelling appropriate behaviour, so we can, in our behaviour, model to carers and parents the best way that they can support the patient. So I think subtly drawing their attention to the fact that we want to talk to the patient and not necessarily talk to them, that we need to understand the patient, what the patient is feeling, and not what the carer is feeling. I think, Elica, you made a really good point about medical records. So people with an intellectual disability may struggle to maintain good records about their health because they've got complex needs. They've seen many doctors and professionals, and they've often been given information in a format that they can't understand. And I suppose people with an intellectual disability are also, their journey is a lifelong journey. It's not just an isolated one for a disease or an illness that you can sort of sign off and tuck away in their past history. It's a lifelong change and a lifelong journey, and the people providing that care will all change along that person's lifetime. So their carers will change, their doctors will retire, their parents will age and die, relatives and siblings will move away or can't care anymore, and parents will move as well. So a person's medical record becomes a really vital bit of information that they can carry from one person to another, from one organisation to another, and that maybe that's a care organisation or a doctor's. So I think it's really important that the information we write down is really accurate and timely and relevant to the patient, because I suppose in general practice we may be the one who's carrying that information and helping put that information down for the patient to take on their journey, and that's a journey that's far beyond our careers. Generally, it's beyond the paediatrician and it's beyond the general practitioner, because patients will move on and change, and we all have to have that record that we're responsible for to move with that patient. So we need the record that travels with the patient, and we need one that's accessible, and we need one that is detailed to assist the patient moving forward. So thanks, Elica.
After I see the doctor, you should ask me what I need. I need to understand what I do next, and the doctor will do next. Example 1, send referred to other health services. 2, in writing would be good, because sometimes I need to hear and read the information 3 times to understand and remember. I need to have my next appointment time written down for me in my diary for the carrots and my personal phone for me to remember.
And once again, Alicia's reminded us of the importance of that communication, isn't it? Making sure at the end of the communication, we've got a very detailed plan about what's going to happen after the consultation, what the patient needs to do, and who's going to assist them to do that. And writing it down for some people may be really important. Talking to the carer, maybe phoning the house or residential facility where someone's living to make sure that those things are going to happen. So whether it's a patient needs a blood test, whether it's their next appointment, who's going to help, I think it's all really important. Even writing that down, giving a copy of the consultation notes to someone who can assist the patient, or writing it down for the patient, when the next appointment is, and what we expect to happen in the meantime, and making sure that that's given in a format that the patient can understand. I think we just have to go the extra mile with that, and to allow that communication to happen. So thanks, Elicia.
Talk to me. Okay. When I go to the GP, they talk to my mother, not me. I can understand everything that doctor is saying and can make my decisions, yet they speak about me over never to me. When the doctor makes appointments, they make them with my mother, not me. I am an adult. You need to respect me before my mom. My intellectual disability doesn't mean that I think and understand like a kid. They to look at me, look closely at me when talking to me. Allow me time to think and speak. Some people can't speak, but we can all communicate through our eyes and body language. Give us time to show you what we need and how you can help. Take notes. Take the time to make detailed notes to put in my bio. It takes time to get to know a person, their reactions, moods, how they usually are on that day, good day, and what is bad day for them.
Thanks, Alicia. I think we always need to remind ourselves that it's the patient that we should always be directing our attention to, really without exception. And others are there just to assist and to facilitate and to help with the patient's consent. And maybe if the patient doesn't understand what we're saying, then maybe we should try to say things in a different way, in a way that they do understand, and not just turning to their support worker to do that. These aren't really your standard consultations. You do need to slow things down, go back to basics, and use all our skills as health professionals. And because they're complex and important consultations, and we can have devastating consequences if we get things wrong. But if we get it right, they can often be the most rewarding consultations of the day. So just go to the next slide there, Alicia. So we've got a slide there.
Visual aids. Some people can understand better when you explain things using visual aids, like drawing and pictures, maps, post-its, document apps.
So I think sometimes we forget that our patients may not have the health literacy that we have, and they've been never given the knowledge in a way that they can understand to actually use to describe their health concerns. So I think using all different visual aids is really important, and that's taking the time to give that information over is an important thing that we need to do as health professionals. And also to remember that some people with intellectual disability will agree with anything you say. So it's really important that we ask our questions in a way that doesn't lead the patient just to agree with us. So thanks, Alicia.
Communication aids. Easy read documents are good. Easy to understand language. Have pictures to explain information. Enough and encourage the person to use their communication aid to express themselves in the appointment. Many use childhood stories, which are short stories explained as childhood citation.
I think these are really important here, because I think and the communication aids, often we need to prepare early, and hopefully the SPIDAH project can help give us some access to some resources that we can use and to think about using in future. So I'll go to the next slide there, Alicia. I think we're...
My good health care examples. I must say that I haven't had a good experience with a GP yet. I feel like I'm a member, not a person. But it is possible to get good health care. The language you use doesn't have to be perfect. Don't shy away from questions because you don't want to make a mistake. If we can see that you value and respect that, that is most important. Thank you for working to change that experience.
Thanks, Alicia. I think it is really important that we do listen to this really important message and that the barriers that have been put up, because it's we can do things better and we can show leadership. No matter what rung of the healthcare system you're on or what role you play, I think we can all teach each other how to treat people with respect and how to communicate better for better health outcomes for each other. Thanks. And I think we're just getting to, is that the last slide for Elicia?
Summary 6 key points. 1, that they talk to me. 2, ask me what I need. 3, look at my personal health card. 4, don't assume something is because of my disability. 5, help me stay healthy by suggesting early appointment and preventative health checks. The last one is keep in mind that any time there is a change in how I act or what I can do, you should check this in this order. Physical health, then mental health, then what has been happening in my life lately.
And thanks, Alicia. I think it's a great summary of the end, and Alicia is alluding to the diagnostic overshadowing. When someone mistakenly attributes a person's symptoms to their disability, and we always have to remember that the physical causes and the other causes before just putting it down to someone's disability there. Really, so today we've spoken about reasonable adjustments and we've gone through it. I know we're sort of really getting to the end of the time. I just wanted to reiterate that reasonable adjustments are small adaptations of practice that can have a big impact on a person's personal health care. I'd just like to thank everyone for attending today because we are getting to really close to 8:30 and it is time to wrap up. I'd really like to thank Elicia for her help today and for her valuable insight into this really important topic. And it's been fantastic working with you, Elicia, for the meetings beforehand. I'd also like to acknowledge Jana, who's in the background. I don't know if you can just give a wave. Jana. Jana's been a great support person for Elicia, and if we're talking about reasonable adjustments, that is how to use a support worker, someone who you don't even really know who's there, but has put in a lot of a tremendous amount of work to facilitate and allow Elicia to present today. And I'd really like to thank you for your contribution today. We're probably really getting to the end of the session, so I'd like to remind everyone about the HealthPathways. And they're always up to date. There is an evaluation slide there, so if you click on that, and I'd like to remind everyone of the next ECHO session, which will be on the 2nd of August. That's the Tuesday morning at the new time of 7:30. And that's entitled Intellectual Disability and Annual Health Assessments, where we'll be discussing the CHAP tool. I don't know if you've experienced the CHAP tool, but that's something that we can learn more about. And our subject matter expert will be Professor Nick Lennox, who's the Senior Medical Advisor and Disability and Health for the Department of Health. So we're really looking forward to that session. So it brings up to 8:30. So thank you everyone for joining us. I think it's been an important topic, the reasonable adjustments, and I hope everyone has a great day from here on. Thank you.